Hello, I'm Dr. Pujita, fertility consultant at Akkineni Hospitals, wishing you good health. Today, we'll review some important points. Please stay engaged and take notes.
Welcome to this explainer. Today, we're diving into what is arguably the absolute most anticipated milestone of your entire fertility journey, the embryo transfer. I mean, think about it. This procedure is literally the ultimate culmination of all your hard work. It all comes down to finding that perfect combination of the seed and the soil. It's this incredibly critical moment where cutting-edge science meets your body's natural receptivity. So here's our roadmap for today. We'll hit selecting the embryo, preparing the uterus, the transfer procedure, understanding success rates, and finally, support beyond the transfer. Let's jump right in. Section 1, selecting the best embryos, or as we called it, the seed. Now, you might be wondering, why do doctors so often prefer waiting for the blastocyst stage around day 5 or 6? Well, while a day 3 cleavage stage transfer does get the embryo back into the uterus sooner, that blastocyst stage is just, well, it's way more developed. Waiting those extra couple of days simply gives us a much better ability to predict the embryo's viability, which directly correlates with significantly higher implantation rates. And you know what really takes the selection to the next level? Genetic testing, or PGT. By making sure the embryo is euploid, which is just a fancy way of saying chromosomally normal, we're practically preventing the transmission of inherited diseases and identifying the healthiest possible embryos. This is an absolute game changer, guys, because it directly reduces the risk of miscarriage, especially for those of advanced maternal age. So what about the whole single versus double embryo transfer debate? Well, one totally crucial point stands out here. For most patients, transferring just a single, high-quality embryo offers excellent success rates, and it completely avoids the really high risks and complications of carrying multiples. Double embryo transfers actually carry a whopping 20 to 40% risk of a multiple pregnancy. Because of that, they're typically reserved for very specific scenarios, like older maternal age or if you've had previous failed cycles. Moving on to Section 2, preparing the uterus, also known as the soil. Okay, I want you to lock this specific number into your brain. 8 to 12 millimeters. That is the optimal endometrial thickness your doctor is looking for on a transvaginal ultrasound before giving you the green light. Aligning less than 7 millimeters might kind of drag down your implantation success, and honestly, going over 14 millimeters doesn't really offer any added benefit at all. To build that perfect lining, your doctor might use one of 3 main protocols. You've got the natural cycle, which just relies on your own ovulation. Then there's the stimulated cycle, using estrogen supplements. And finally, the medicated frozen transfer. Fun fact, the medicated frozen transfer is actually the most common approach used today. It offers highly flexible timing and excellent success rates by relying on a full hormone replacement of both estrogen and progesterone. Now, precise monitoring is absolutely necessary here because timing is literally everything. From the start of your cycle, we spend about 10 to 14 days just building up that lining. But here's the catch. We're aiming for a very brief 4 to 5 day receptivity window, which usually falls somewhere between days 19 and 23. That is the exact magic moment when your uterus is perfectly ready to accept the embryo. But wait, before we even reach that window, we have to make sure the path is clear. Correcting any anatomical roadblocks is a mandatory step that significantly improves your overall outcomes. Things like the hysteroscopic removal of polyps, surgically removing submucous fibroids that might distort the cavity, or treating intrauterine adhesions, these are all totally essential to normalizing your anatomy. Section 3, the transfer procedure. Let's demystify this medical step. You know, the procedure itself actually requires very minimal preparation. Often they just ask you to come in with a full bladder, which, yeah, can be a bit uncomfortable, but it really helps with the ultrasound visibility. The whole thing is designed to be a super gentle, atraumatic process, carefully guided by ultrasound. A soft catheter is gently passed through the cervix, and the embryo, which is loaded in this tiny little volume of media, is safely released right where it needs to be. Now, you might find yourself choosing between a fresh or a frozen transfer. A fresh transfer happens just days after your retrieval, right in that same cycle. But frozen transfers, they are incredibly advantageous. Why? Because they actually give your body time to recover from all those intense retrieval medications. And while you're recovering, your uterus can be optimally prepared, which leads to similar and in many cases, even better pregnancy rates. I also want to throw in a quick note here. Certain special anatomical conditions absolutely have to be managed first. For example, if an ultrasound spots a hydrocele pinx, which is a fluid-filled fallopian tube, that can drastically slash your implantation rates by 25 to 50%. No way we want that. That's exactly why surgical removal prior to the transfer is highly recommended to protect your chances of success. Section 4. Understanding success rates, the data of hope. Okay, we need to acknowledge a harsh but super important reality here. Success rates for any individual cycle are highly dependent on your age. It's just a biological fact that implantation odds naturally decrease over time. Women under 35 generally see a 40 to 50% clinical pregnancy rate per transfer. But as you can see, that shifts down to about 15 to 25% for women over 40. But hold on, look at this wildly encouraging number right here. 80 to 90%. That is the cumulative success rate of achieving a live birth after 5 or more transfers. Think about that for a second. This data proves that your persistence is deeply, deeply rewarded. So while the per-cycle rate might sometimes seem a little daunting, sticking with the process drastically shifts the odds back in your favor. Section 5. Support beyond the transfer, the emotional journey. So, the physical procedure is done, the catheter is out, you're dressed, and you're heading home. But what happens as you leave the clinic and enter that intense psychological trial we all universally know as the 2-week wait? Well, physically, you're going to continue your essential progesterone support to sustain the early pregnancy, usually for about 10 to 12 weeks. And you'll definitely want to limit any strenuous exercise, though moderate activity is usually fine. But let's be real, the true challenge is often navigating the heavy emotional weight. The psychological intensity during this waiting period is just profound. Recognizing this immense toll, leading institutions like Akkineni Hospitals rightly champion the integration of long-term psychological support and counseling right into your immediate post-transfer care plan. Having access to professional support groups and stress management resources, it's absolutely critical. It helps you safely navigate the emotional roller coaster of both positive and negative results. To sum up everything we've talked about today, maximizing your IVF success is this really intricate balance. It's pristine embryo selection, tailored uterine preparation, flawless physical technique, and holistic emotional support, all working together. It really is the ultimate team effort between you, your body, and your clinic. So, armed with this roadmap, I want to leave you with one final thought. Are you ready to take control of these milestones and truly master the final frontier of your IVF journey? I hope you use this knowledge to ask your doctors the right questions, to deeply understand your protocols, and to walk into your transfer day with absolute confidence.